So are you ready, Dr. Lakhvinder?
Yes, sir.
So we will start in 1 minute. Right? So good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 20D, which is transfusion medicine, and we are streaming live from PGI Chandigarh. And today we have a very interesting topic. This is session 1 of this topic, which is transfusion of blood to the recipient. In session 2, we shall be addressing adverse effects of transfusion. And to talk on that, we have somebody who is very well accomplished in transfusion medicine, which is Dr. Lakhvinder Singh. He is an MBBS MD transfusion medicine. Presently, is an assistant professor in the Department of Transfusion Medicine, PGI Chandigarh, member of the Patient Blood Management Subgroup of Clinical Transfusion Working Party, International Society of Blood Transfusion. He has been awarded PG Fellowship Award as the first rank in Transcon 2011, multiple publications in national and international journals, member of manuscript review panel of IJHBT, AJTS and IJPE, with areas of interest in clinical transfusion practice, patient blood management, Haemovigilance, which is adverse transfusion reactions, and Immunohematology. Before I ask Dr. Lakhvinder Singh to start, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Lakhvinder sir, please share your screen and let us start. Thank you so much.
Thank you, sir. Uh, Before I start, I want to thank you for giving me a chance to discuss this topic with the students. And I would be speaking to you today regarding the transfusion of blood components. We start with the presentation. So the topic for today's discussion is transfusion of blood to the recipients. And second part would be, as sir has already discussed, that adverse transfer would be taken in the subsequent lectures.
Just
So,
share your screen, sir.
is my screen visible?
Yes, please
Yeah.
start. Thank you so much.
So, transfusion of blood. So, initially it used to be like we give red cell, initially it used to be whole blood. And for any as well the indication, we used to transfuse our blood. But nowadays, so much of research has been there. So, now we know how to actually decide which component is required. So, we know that the indication for blood transfusion, various components. Like in our previous lecture, Dr. Hari has explained, we have the red cell components, we have the platelet components, we have the plasma components. In the red cell components, we have the whole blood, which is nowadays not used. Then packed red blood cells, PRBC, then additive solution, leukoreduced packed red cell, then small pediatric bags are there. Then comes the platelet component, platelet-rich plasma, platelet concentrate, apheresis platelets, and buffalo pooled platelets. In the plasma components, we have the fresh frozen plasma, cryo plasma, cryoprecipitate, and the pool precipitate. But now the question comes, which components to transfuse? How do we decide? So we have to know the indication of each component which we are going to transfuse, then when to transfuse. What are the transfusion triggers? Like for red cell component, at what hemoglobin we are going to transfuse? Is there any other parameters which help us decide whether the patient requires transfusion or not? Because we all know that blood transfusion, the blood component, it's a biological fluid. So if it is being transfused without any clear indication, it can cause more harm than doing any benefit to the patient. Then the third question comes, how much to transfuse, the dosage. How much red cells are required? 1 unit is required or 3 units are required. So that, how do we decide on that? Then how to transfuse? There should have be a process flow. How do we take the sample and how the requisition of fill, how the cross match is done, and then how it is transfused. That I'll discuss. Then how to monitor the transfusion. And then last is suspected transfusion reaction. The last two parts I'll be discussing in the next lecture. So before we start the transfusion and we give blood, before that there are some prerequisites. We have to plan. We are going to give this patient transfusion, and what are the prerequisites for this? We have to prepare the patient, and then the person who is giving the transfusion should be expert in it, and then he or she should give the transfusion. So first thing before transfusion is informed consent. I'll discuss each point in detail. First is informed consent is required. Second, recipient history and baseline assessment. Then pre-transfusion sample. What are the requirements for pre-transfusion sample? Any prophylactic medicines if required, IV access. Then infusion equipment and compatible IV solution, patient identification, documentation. This is before you start the transfusion. We all are aware that blood is a drug. In India, the blood is described under the Drug and Cosmetic Act, and we have to follow all the rules written in the Drug and Cosmetic Act. So it's a drug as per the Part 12B and Part 12C or Schedule F, the Drug and Cosmetic Act. So whatever the requirements are, they are regulatory requirements. So we have to fulfill all the requirements before starting the transfusion. Like first is the informed consent. Like for any surgical procedure we always obtain the informed consent. In case of blood transfusion also, it is required, it is mandatory, it's a regulatory requirement. The patient should be informed about his or her need for blood, what are the alternatives available, as well as the risk involved in transfusion and non-transfusion. There should be a written consent in the language he or she understands, best only after providing the information. For minor and unconscious patient, like for any other informed consent, it can be taken by next of kin. And this is a regulatory requirement. And now the question of why should I take the informed consent? First is blood is a biological fluid, is immunologically active. It causes mild to severe reaction, but sometimes it can even cause life-threatening reactions also, like trolley, teco, which can even cause mortality. So that's why we are taking the informed consent before starting a blood transfusion. And blood being a biological fluid, it's as good as a transplant, because we are transfusing the WBCs also, platelets also. So many antigens are being transfused, so it may cause any kind of reaction. Second important point is, despite mandatory screening of blood-borne infection such as HIV, hepatitis B, C, syphilis, and malaria, these are the 5 infections which we screen before releasing the blood for transfusion. The risk of acquiring this infection is not totally eliminated. Still, there is small chance that if the blood donor is in the window period means the day when the patient the donor has acquired an infection to the day when our tests like ELISA or NAT they can detect that particular infection. So if the donor is in that period, then our test cannot pick the infection. So there is still a small risk that our blood transfusion may transmit these infections. And like any other procedure, recipient has the right to choose or refuse transfusion, because there are certain group of patients also who do not accept the blood transfusion. Jonah witnesses are there, they don't accept any blood transfusions. And that was all about the informed consent. Now coming to the recipient history and baseline assessment. We generally tend to forget these important points because this help us to decide which component is required. Any specialized procedure is required for the component. Generally, we get the form without diagnosis, without any other information, that just two PRBCs are required. In that case, we are helpless. We cannot decide which component is required for this particular patient. So, whenever you receive a form for blood transfusion, you must have the complete history and you must assess the baseline parameters also. First thing, assess whether the patient is at increased risk of a transfusion reaction, like patient with thalassemia, sickle cell, or other multi-transfused patient, or those patients who have a history of previous transfusion and any adverse reaction. Because once you have a history of allergic reaction, then the chances of severe reaction increase in the subsequent transfusions. So if the patient has a history of some allergic reaction, so you have to decide whether any pre-medication would be required in allergic reaction. Can you give antihistamine before the transfusion? So these all things you have to decide. And any specialized component required, like if on the form it's mentioned that patient has a history of febrile reaction during transfusion. So you know that patient is may develop febrile reaction again. So you can reduce the blood count, because when you remove the leukocytes from the blood bag, then the chances of febrile reaction go down. This will, you can only judge all these points only if you have the complete recipient history. Then history of any comorbidity, like patient who has a renal or cardiopulmonary disease are at a higher risk of circulatory overload. TACO is transfusion associated circulatory overload. So in this patient, either we can give blood bag in small parts, like if we have a 300 ml bag, it can be transfused over a period of 4 to 6 hours. Or we can make two bags, one bag is transfused and you wait for some time and the second bag is transfused. So we can decide how to transfuse to prevent the occurrence of TACO. Then baseline physical assessment, the staff nurse or the resident doctor who is transfusing the blood, he or she must get all these parameters checked. First is the temperature, because if patient is febrile, and then like if you transfuse platelet components to a febrile patient, then the destruction of the platelet is a higher rate. You will not get the required increment. Pulse rate, respiratory rate, blood pressure, oxygen saturation. Because whenever there is a transfusion reaction, you need to know the baseline parameter. Like if I give an example, for a febrile non-hemolytic transfusion reaction, febrile reaction, there has to be 1 degree rise of temperature from the pre-transfusion value. You can judge if there is a 1 degree rise only if you know the pre-transfusion value. If I say pulse rate, patient will had increased pulse rate after blood transfusion. So I have to know what was the pulse rate before transfusion. Maybe initially also the pulse rate was high. So these parameters are required before starting the transfusion. Patient may have decrease in the blood pressure in hemolytic transfusion reaction. So we have to know whether there is a fall in blood pressure or patient is already having low blood pressure. So third thing was pre-transfusion sample. This is very important uh, because when you take the pre-transfusion sample and if you by mistake mix up the sample, the patient may get the wrong blood transfusion. So most important and the crucial point in the chain, the process for which I was talking about is the pre-transfusion sample. Pre-transfusion sample is required for all the red cell components, because for red cell components, compatibility testing, in simple words, we call it cross match, that is performed. But for platelets and the plasma components, no cross match is required. They are given blood group specific. So if you have the historical blood group in your system or in your register, patient has received red cell in the past, then you need not ask for a fresh sample. Only by historical blood group you can issue the platelets or the plasma component, or it may depend on the policy you are following in your hospital. And the sample has to be obtained within 3 days of transfusion. Draw day considered to be day 1. We are taking the 72 hours window because a person who has received transfusion may take 3 to 4 days to develop some new antibody. There may be change in the immunological profile of the blood within 72 hours. So after 3 days we do not use the sample. And after, if you have cross-matched a blood unit or on day 1, on day 4 that blood unit cannot be transfused because that unit may or may not be compatible now. So after 3 days, we have to receive back the blood. We have to cross-match fresh blood for that patient. And for pre-transfusion sampling, we prefer the EDTA samples. Why EDTA sample is that because due to ease of handling, because sometimes we have to do the blood grouping, antigen profiling, so that red cell morphology is maintained as compared to the serum sample. The coagulated samples. Red blood cells from an anticoagulated samples are ideal for preparing a uniform cell suspension for testing. Second, the serum, if we take a coagulated sample, it may contain small fibrin clots that can be difficult to distinguish from true agglutination. However, there is one drawback of anticoagulated sample because it's inactivate the complement. So the antibodies like JK antibodies, which bind the complement, and they may be missed if you use the anticoagulated sample. But despite this possibility, the benefits of using anticoagulated specimen outweigh the potential risk. And moreover, nowadays the techniques the used for cross matching are very sensitive. So even if complement is not there, they can detect the antibodies also. Second, next point is which we have to consider is whether we have to give prophylactic medicines, pre-medication or not. There have been a practice, a patient who has febrile reaction or allergic reaction or who wants transfusion, they pre-medicate the patient with antihistaminic and febrile, some anti-febrile drugs like paracetamol or acetaminophen. That should not be practiced in general because recent evidence indicates use of pre-medication does not minimize transfusion-related adverse events. However, the quality of evidence is low to moderate, but it's there. So in absence of definitive evidence-based studies, pre-transfusion medication to prevent transfusion reaction should not be encouraged. Because suppose if you have issued a wrong blood and patient is getting hemolytic transfusion reaction, so the only sign the patient may develop is increasing the temperature. If we are given high dose of paracetamol, there may not be increasing temperature, and you'll come to know about the reaction only after a large volume of blood has been transferred. So the severity of reaction may increase. And anti-allergic drugs like antihistaminics, they are used to treat allergic symptoms once they arise. It's an antihistaminic. It will block the histamine receptors, but it will not prevent the release of histamine. So if patient has a history of allergic reaction and if you give anti-allergics before the transfusion, then there are chances that patient may develop an anaphylactic reaction because histamine will be there. How the receptors at the periphery may be blocked, but some other receptor may get activated and patient may have uh, anaphylactic reaction. And pre-medication with acetaminophen reduces the overall incidence of febrile reaction without impairing the ability to detect other complications of transfusion. So yes, paracetamol has some role to decrease the severity of the disease of the febrile reaction, but it may not prevent it completely. So pre-medication should be given to multi-transfused patient with history of repeated febrile or allergic reaction, not in general. And it has to be given 30 minutes before the transfusion. You can give paracetamol and antihistaminic because they act within 15 to 20 minutes. But if you are giving steroids, like patient is thalassemic, dependent on transfusion, having repeated allergic reactions, so you have to prevent that reaction. So in that particular case, steroids are indicated, but they have to be given at least 2 to 4 hours before the transfusion. So timing of pre-medication is also very important to get the desired effect. Uh, Next important is IV access because sometimes what happens, blood is issued, blood is kept outside and you don't have the IV access. Blood is not transfused, so blood gets wasted. So we have we must obtain a good IV access, and the size IV size is mentioned here. For the red blood cells, if you want to give rapid transfusion, like in massively transfused patient, then 16 to 18 days. Or through the central line also you can give the transfusion, or any peripheral cut down can be done and you can insert the tube for the transfusion. And red blood cells for routine transfusion in adults, 20 to 22 gauge is sufficient. For other blood products, because there are no red cells, so any size will work. For pediatric, 24 gauge cannulas are available. So those can be used, but we have to ensure that transfusion is not rapid and not under pressure. Because with high pressure, if you try to transfuse through a small IV access, then it can cause hemolysis because red cell size is 7 to 8 micrometers. So if the bore of the IV can lyse less than that, the red cell may get lyse and the patient may have some adverse reaction. Next are the infusion equipments. We have the blood warmers. In general, blood warmers are not required because when you start the transfusion, initial 15 minutes you give it very slow, maybe 5 to 6 drops per minute. And if your blood bag is hanging on the bedside for 15 to 20 minutes with the ambient room temperature of 25 degrees Celsius, and within 15 minutes it comes to the room temperature, which is a room temperature. So in that case, it is not required. So when they are required, so infusion of cold components can cause hypothermia and cardiac complication only when it is transfused through a central venous device directly into the right atrium, and it is transfused immediately after issue from the blood bank, like in cases where massive transfusion is going on. And second important thing is, which is sometimes practice, it's wrong practice, blood should not be warmed by placing it in a microwave on a heat source. Sometimes the blood is kept under the hot water taps. That is a wrong practice. Not to keep the blood in hot water bowls, because there's a storage temperature, there's an ambient temperature for red cells, which is the 4 to 6 degrees Celsius, and up to 37 degrees Celsius you can uh, uh, thaw your red cells. After 45 degrees Celsius, the red cell begin to lyse, and no other device should be used to warm the blood. We have some FDA approved blood warmers. Like you can see three pictures here. These are three types of blood warmers. They should have a visible thermometer, an audible warning alarm, and should be properly maintained. Like in this picture, you can see there's a display here. It displays the temperature, and if the temperature goes beyond 37 degrees Celsius, it gives an alarm so that we can take out the blood component. So it is not wasted. So when do we have to warm the blood? In general electric transfusion, there is no need to warm the blood, but it takes 2 to 4 hours to transfuse and the blood comes to a normal temperature. Warm blood is most commonly required in large volume rapid transfusion, like massive blood transfusion. In adults, greater than 50 ml per kg per hour if you're giving, is generally given in obstetric patients when they have postpartum hemorrhage, severe postpartum hemorrhages, massively bleeding trauma patients are there. In children, 15 ml per kg per hour, like we doing exchange transfusions. Before doing exchange transfusion, we must keep the blood outside for something or use a blood warmer. In the neonates are more prone to develop hypothermia as compared to adults. Exchange transfusion I have already this. And patients with clinically significant cold agglutinates. Sometimes patients develop some IgM type of antibody which are cold agglutinates, which reacted uh, cold temperature. So when you warm the blood at 7 degrees Celsius and then you transfuse, and patient do not complain of any reaction. So it's a general practice is whenever we have cold agglutinates, it's better to warm the blood and then transfuse. So, then after warming the blood, you require BT set, blood transfusion set. First thing, very important, the infusion sets which are used for the transfusion of normal saline or any other fluid should not be used for the BT set, because the blood components, maybe platelets or FFPD, maybe have small clots, micro aggregates, or some clumps or something. If those clots and microaggregates are transfused with the blood component, they can activate the coagulation system, or they may lead to coagulation cascade and may cause some thrombotic problems in the patient. So it's always advisable, whatever blood components are you transfusing, you have to use a blood transfusion set. No other infusion set you can use. This set has 17260 micron filter to remove the microaggregates and fibrin tags, and all blood components should be transfused through the BT set. and you have to change the BT set every 4 units transfuse consecutively. Or you can follow the manufacturer instructions. Some say that after every blood transfusion, you have to change the BT set. If you have transfused the red cells through a BT set, do not transfuse platelets from the same BT set. You have to change the BT set. Better to use new BT sets for each blood component involved. And the bottom line is leukoreduction filters remove leukocytes also. These BT sets are the first generation BT sets. We have the second and the third generation BT sets which remove the leukocytes also. In general, we do not require this leukoreduction filter, but if patient has a history of febrile reaction, then we can use it. So that leukocytes are removed, only the red cells are transfused. So that will help to bring down the incidence of febrile reaction. Now, important question is next is duration for blood transfusion. In how much time you have to transfuse that particular blood component? Whole blood and PRBC, it has to be transfused within half an hour of removing from the refrigerator. Refrigerator means blood storage refrigerator, which maintains the temperature between 4 to 6 degrees Celsius. And the transfusion has to be completed in less than 4 hours. If the period is exceeded, then do not use it. Suppose a patient, as I discussed earlier, patient has some renal disease or cardiac disease. You do not want to give rapid transfusion, then you may divide the blood components into two parts. Keep one part inside the refrigerator and the second part can be transfused over 4 hours. Then you wait for 1 hour or 2 hours. Then you start the second component. But once the blood component has been punctured, then it cannot be kept outside for more than 4 hours. Platelet concentration has to be started immediately, completed within half an hour, because volume is only 50 to 60 ml in a platelet concentrate. If it is an SDAP, volume is 200 ml, still it can be transfused within half an hour to 40 minutes. Fresh frozen plasma, FFP, again half an hour. Cryoprecipitate, again half an hour, it has to be transfused. Why there is a time limit? Because there is a risk of bacterial proliferation of or loss of function blood product once they have been removed from the correct storage condition. Platelets, if the temperature rise, platelet lose their hemostatic ability, and the coagulation factors may go down in F. And if blood is kept outside from the blood bank refrigerator for more than 30 minutes and is not transfused, it should be sent back to the laboratory. Because if the blood reaches after 3-4 hours and was kept outside in the ward, then blood is not fit for any other transfusion. Then suggested rate of transfusion. At what rate we have to transfuse? The rate will differ for adults and the pediatric population, because the size of the IV cannula which you are using is different. For whole blood, because it's less viscous, you can transfuse in adults 150 to 200 ml per hour. That means 400 ml bag, 350 ml bag will be transfused within 2 hours. For PRBC, 100 to 150, because it is more viscous. And for platelets and plasma, we can transfuse 150 to 300 ml per hour. That means you can same, it comes at one bag has around 150 to 200 ml, so it can be transfused in half an hour. In pediatric population, the rates are given: whole blood 2 to 5, pack size is same, and platelets say 1 to 2 ml per minute can be transfused. And for pediatric population, because they are so sensitive to the increase in the volume, circulatory overload, and hypothermia, so we have the infusion pumps also available. Those pumps can be used, and they are very precise in distributing the blood component. So if you set them at 1 ml per minute, so 1 ml per minute would be transfused. So infusion pumps can be used for pediatric population. Then next important thing is before starting the transfusion, because sometimes there's a practice we issue the blood to outside hospitals also. So we have to ensure that certain emergency equipments are there at the bedside, so that whenever there is a transfusion reaction or some other problem occur to the patient, we can well manage. Like normal line and a new administration set should be there. Because once there's the HTR, we have to discount. HTR means hemolytic transfusion reaction. Once there is a reaction, you have to stop the blood, but you have to keep the IV access paid. So you start the normal line through a new administration set. appropriate medication to treat the reaction and its sequel. Like patient develop trolley, so you should have oxygen available. The patient allergic reaction, you should have your antihistaminic steroids available. Patient has anaphylactic reaction, so immediately if you give adrenaline, then you can reverse the reaction. Otherwise, there can be very serious sequelae to this. And mechanism to activate emergency resuscitation measures in the event of a severe reaction. Because in Trali, we have seen the mortality is very high. The mortality used to be very high, but nowadays, because with the awareness has improved, so as soon as the patient oxygen saturation dips because of Trali, and the physicians are able to diagnose that patient is going to develop Trali or TACO, immediately they start the oxygen. And if the saturation further falls, immediately they intubate the patient. So intubation may be required at times, and we have found that if you intubate the patient immediately, then within 6 hours patient improves, because in Trali, patients generally improve within 24 hours. But if the treatment is started early, then within 6 hours patient improves. Ventilatory assistance and oxygen source, as I've already discussed. Next most important part is patient identification. Patient identification is important at 2 points. First is when you are taking the blood sample. Second is when you are transfusing a blood component. So if you take a wrong blood sample, wrong blood will be issued. And when you are transfusing a blood component, if you are not identifying the patient, because sometimes what happens, you identify the patient by the ward number or the bed number. So one patient may have gone for ultrasound and the other patient lying on the bed, and you start transfusion. It has happened. So it's very important in case of blood transfusion that we identify the patient positive. So we have to positively identify the patient. You have to ask the name. Don't ask like this that your name is Ram. You have to ask what is your name, because if you are named Ram, then he may say ha, na, then but it may not be clear to you. So always ask what is your name, your father's name, or your address. If the patient is unconscious or under some influence of drug, then you may ask the patient attendants, or you may see the file, but you have to confirm. And after drawing the sample, you have to label the tooth before leaving the patient, because labeling sample away from the patient greatly increases the risk of mislabeling. And now then you have to document that you have drawn the blood sample. If any discrepancy are discovered, they must be satisfactorily resolved prior to collecting a pre-transfusion sample. It's very important, so I'm repeating, errors in sample labeling and patient identification are the leading cause of acute hemolytic transfusion reaction, and it is totally preventable, and it's potentially fatal complication. So we have to be very careful about this. So these are two that sample should be labeled properly in a continuous, uninterrupted event. It's not like I've taken the sample, I label it after doing some gastric lavage or some other procedure. No. If you've taken the sample, immediately label the sample and sign on the sample. It should be an uninterrupted event involving only one patient and one healthcare provider. If one resident is taking a sample, he or she should label the tubes and send the sample to the blood bank. Not like one has taken a sample and the other is filling the form. It should not happen. And you have to label the sample before leaving the sample circle. Like you have to label the sample at the bedside of the patient. Then comes the uh, documentation. It is a very important part of blood transfusion, because, as I've already discussed, it's a regulatory requirement. Every 5 years, the license of the blood bank is renewed. All the documents, the drug inspector comes, he checks all the documents, and then the license is renewed. So it's very important to do proper documentation. First is physician order for blood transfusion. Physician order should be there in the file, that why the patient requires blood, how much blood is required, all these things should be there. Then when you start the transfusion, you have to write at what time the transfusion was started, time it got completed, volume and type of blood component you have transfused, unique donation number of the blood, like the blood donor number is there, any adverse effect patient had, and you have to record in the patient notes type and volume again, unique donation number each unit transfused, blood group we have to mention because it becomes an historical blood group, time signature of the person who administered the blood, and record time of completion in the patient file. So next question, big question is which component we have to transfuse. Sorry for this. Which component you have to transfuse, whether red cells to be given, plasma to be given, platelet components to be given, granulocytes to be given, and when we have to transfuse these components. So red cell components, they are basically the only indication in one line is to correct or prevent the tissue hypoxia. Thus, the parameter of choice for making decision should be intracellular PO2. Directly, you cannot measure it. So, other parameters are used like hemoglobin, where the patient has acidosis, if the patient has increased heart rate. So, these are all the parameters which tells that yes, patient probably is developing tissue hypoxia. Plasma components. They can be either given prophylactically when bleeding is not there, but has higher chances of to get a bleed. So we give them prophylactically plasma component or therapeutic. Similarly, for platelet component, it may be prophylactically if there is no bleed, or when bleed is there, then we give for therapeutic indication. Or some platelet function defects are there, then also you get the platelet components. Granulocyte components, febrile neutropenias, like after a patient has undergone an hematopoietic stem cell transplantation. Immediately after that phase, the patient has pancytopenia. Red cells are down, granulocytes are down. At that phase, patient, if the neutrophil does not improve, the patient develops febrile neutropenias, fungal infection, then the granulocytes component, they are very helpful and they are life-saving elements. So coming first to the red cell components, first is the whole blood. Nowadays, whole blood is very rarely used. There are centers in India or some other countries who don't have the access to the blood component preparation, as Dr. Hari explained in the previous class. They are using the whole blood. But in the modern transfusion practice, there is as no role of whole blood. So in the few indications are exchange transfusion in neonates. Because when you do the exchange transfusion, then you give packed cells also and the plasma also. So if you know the group, which group packed cell or plasma is to be given, then you can give the whole blood. But in our center, various centers, what we are doing is we mix the red cell and the plasma, then it is transfused. And when packed cells are not available, like in various centers in India, they can be used for acute bleeding condition where there is also a need to correct hypovolemia. Battlefield injuries, road traffic injuries are there. Initially in 1950s, around only whole blood was being used. In 1960s, the packed cell components came. The component preparation started. Now again, the interest is toward the whole blood. Maybe it has a better role in correcting the hypovolemia in the trauma and other massive bleeds. So I'll discuss that in massive bleed part. But the problem with the whole blood is platelet function is rapidly lost during the when the whole blood is stored at 4 degrees Celsius. Because platelets are stored at room temperature. Whole blood stored at 4 degrees Celsius. So when platelet function is lost. But again, nowadays the research is going on that platelet can be stored at 4 degrees Celsius. They are known as the cold storage platelets. So we don't know, maybe in future we'll again start using the whole blood. But that whole blood has to be used within 5 days, because not only platelets, we have to consider coagulation factors also. After 5 days, the coagulation factor goes down. So I'll discuss all that again. So routine use of whole blood should be discouraged because whole blood will contain all the components. A patient who has anemia only require red cells, does not require plasma, platelets. Then why to give extra plasma? And plasma can cause various problems, various adverse reactions. Like plasma can cause allergic reactions. Platelets can cause febrile reaction because leukocytes are there in the platelets, some monocytes are there, and the plasma can cause severe reaction like trolley. It is known that more of plasma you transfuse, the more of bad lung you develop. It is because of trolley. That's why the routine use of whole blood should be discouraged. Next comes the red cell components, the packed red cell components. The various types of red cell components are there that have been discussed, so I'll not discuss that here. So basically, we have two types of transfusion threshold. One is a restrictive, and second are the liberal transfusion threshold. At most of the places, this liberal transfusion threshold used to be used. They were using this threshold, saying that more is the hemoglobin, more would be the oxygen carrying capacity, and the outcome would be good. Patient will improve. But now the various there are various RCTs and various studies which have shown that if we are using a restrictive transfusion threshold, then the uh, acute and the 4 weeks mortality is less as compared to patients who get a liberal transfusion threshold. So in the restrictive transfusion threshold, you should not transfuse above 7 gram per deciliter of hemoglobin in patients who are hospitalized, who are hemodynamically stable, including the patients in the ICU. The patient is in ICU and hemoglobin is 7, then you need not to transfuse. And a patient who is going to undergo an orthopedic surgery, cardiac surgery, or has a pre-existing cardiovascular disease, then you can keep a threshold of 8. So we have restricted, we have two type of thresholds, 7 and 8. 7 is for hemodynamically stable patient or HB of 8 for patients who are going to undergo some surgery or have some pre-existing cardiovascular. But these recommendations do not apply to the patient with acute coronary syndrome. Depending on the severity of the MI, coronary disease patient have severe thrombocytopenia and chronic transfusion dependent anemia. Chronic transfusion dependent means a patient like who have some hemoglobinopathies. In that, we do not keep this threshold. I will discuss that also. So restrictive is 7 and 8. 7 for hemodynamically stable patient, 8 who are going to get a surgery done, and pre-existing cardiovascular. Second is a liberal transfusion threshold. Most of the physicians prefer to use this, but evidence is that it is doesn't have any favorable outcome on the of the patient. In fact, transfusing more of blood can increase the chances of mortality because of immunomodulatory properties or some inflammation which is causes the reaction it can cause. So liberal transfusion threshold should has no indication as such. And clinical practice guidelines are not standards, nor can they substitute for the judgment by the physician. Suppose I give an example, a patient who is due for who has undergone surgery. Patient is fine, knee replacement surgery has been done. Patient is remains on the bed, is not mobile. So in that case, even if the HB is 6 or 6.5, you need not to transfuse to increase the HB to 7 or 7.5 because patient is non-ambulatory. Patient is not moving. So patient not moving, the oxygen requirement would be less. So you have to judge whether the oxygen requirement of this patient is high or less. Depending on that, you can decide whether you can push the threshold towards 8 or 9 sometimes. Like in like I said in orthopedic surgery, threshold is 8. But the patient who is going to undergo surgical oncology is a surgical oncology patient, and the tumor is going to bleed a lot. Like Wilms tumor is there, some other vascular tumors are there. In that case, you can keep a threshold of 9 up. We had a patient who had a big osteosarcoma, a very big osteosarcoma. So we, for that patient, we kept a threshold of 9. So these are certain new things which have come up. They say for a hemodynamically stable patient, do not transfuse more than 1 unit. Patient HB is 5, transfuse 1 unit, see the response. If required, then transfuse second unit, maybe next day or after some time. So why give 2 when 1 will do? Single unit red cell transfusion should be the standard for non-bleeding hospitalized patients. 7 and 8 I have already discussed. Do not transfuse more units of blood than absolutely necessary. These are again few recent was from the studies. Do not transfuse more than one red cell unit at a time when transfusion is required in stable non-bleeding patients. Do not transfuse patients based solely on an arbitrary hemoglobin threshold. Like patient just had PPH or patient just had bleeding. So if we had a sample was taken uh, at that time when there was no compensatory mechanism working on, then the HB may be falsely high. So you see the patient, judge the patient properly, see the condition of the patient, and then you decide whether the hemoglobin which we are getting on the blood test is false or true. There may be sample was taken after transfusion lots or normal saline. Then the hemoglobin would be falsely low. So again, we have to judge the patient just not on the basis of an arbitrary hemoglobin threshold. That's why I said these standards are just to are not like substitute for the your physician judgment. And do not try this again. Same. So next, one thing which generally we get confused, but it's very simple to understand compatible blood groups for red cell transfusion. Remember, O negative packed red cells. They are the universal red cell donors. O negative packed red cell. I'm not saying whole blood. It's packed red cell because if we are using whole blood, then in a individual who is O will contain anti-A and anti-B. If transfused to a patient with a group of A or B, can cause hemolysis. So our main is O negative are the universal donor. And but when we talk about plasma, it's the reverse. AB positive plasma will not contain any antibody, neither anti-A or nor B. Because I hope we all remember the Landslinger's rule, which say if an antigen is present in an individual, the corresponding antibody would be absent. So if the blood group is A, then anti-A would be absent, anti-B would be there. So if blood group is AB, then both the antibodies would be absent. So it's a neutral plasma. So for plasma component or platelet component, AB is the universal donor, and for red cell, O is the universal donor. So if patient blood group is A positive, first choice remains A positive or A negative. If A positive are not available, then we can give O positive or O negative. Positive and negative are the RH groups. For O positive, there is no other choice. Only O positive can be given. Similarly for A and give in this chart you can see the bottom line, the RH positive packed red blood cells can be transfused to RH negative patients. Sometimes patient is RH negative, like patient is group is O negative, and the patient comes with trauma, massive blood loss. You do not have enough blood units in your inventory, so you can give O positive, like in older men, post-menopausal females, because there is a 30 to 40% chance that the patient may develop anti-D. But at that moment of time, your main aim is to save the patient. Antibody will develop later. So it's not an art binding that you cannot give O positive to an O negative individual. However, you must obtain the informed consent before you cross the blood group barrier. Then coming to the red cell component in the intensive care unit, it's still the same like in any other patient. Hemodynamically stable patient less than 7 is the transfusion trigger. Post even the post in the post-operative surgical patient who are in the ICU. Now there's a difference. Initially, I said a post-operative surgical patient like osteoarthritis, patient is stable, patient is fine, patient is in the ward. Then even you can consider a trigger of 6 to 6.5 also. But now the patient is in ICU. So in that case, post-operative patient, surgical patient or hemodynamically stable patient with pre-existing cardiovascular disease, threshold is 8. Or if patient develop chest pain, orthostatic hypertension, tachycardia, unresponsive to fluid resuscitation or congestive heart failure. Hemodynamically stable patient with acute coronary disease. Here, American Association of Blood Bank, they do not give any recommendation. They say you see the patient, decide if you want to transfuse or not. Patient is developing acidosis. Then you have to transfuse. The HB may be 11, 12 because the heart is not pumping. The blood is not reaching the tissues. So you may have to consider a higher threshold in patients who are hemodynamically stable with acute coronary syndrome. So coming to next part is red cell transfusion in thalassemia patient. So objectives of transfusion in thalassemia are we have to suppress the overactive erythropoiesis. We all know that in thalassemia there is ineffective erythropoiesis. There is a less hemoglobin is there, so bony deformities develop, and iron toxicity occurs because of downregulation of hepcidin because of active erythropoiesis. To maintain the normal growth spurts in the uh, patients of thalassemia, increase energy and improving academic performance, improved appetite. But we all have to understand that every month they have to come for blood transfusion. They get repeated transfusion reactions. They have abnormal growth spurts, and their academic performance is not very good. So there are so many complications. Some develop some psychiatric problems also. So it's always better, like you can see a picture, you can prevent thalassemia. So awareness is the only answer because even the stem cell transplantation in India, it's difficult to achieve the target for these patients. So threshold for transferring thalassemia patient. The initially it was for the general patient. Now I'm talking about the thalassemia patient. Red cell transfusion should be planned at an interval of 2 to 5 weeks. This interval is decided because pre-transfusion HB should remain more than 9 and post-transfusion hemoglobin should not exceed 12. And there should not be any fluid overload because they are already hyperdynamic circulation. Transfusion process is over within a reasonable time, within 4 hours. Frequency of transfusion is not such that interfere with patient normal activity. You cannot ask the patient to come for transfusion every week or every 5 days. So you have to give them a decent interval. In our center, we are giving a 4 weeks interval, reducing the number of venipuncture. A regular transfusion suppresses ineffective electrophoresis and decreases the chances of iron toxicity. Generally, we think that more of blood we transfuse, the more of iron we are transfusing, so it will cause iron toxicity. That's wrong. One blood unit contains only 200 milligram of iron. It's not a very high iron in a blood unit. The toxicity is because of the hepcidin mediated mechanism. The iron absorption increases because of ineffective erythropoiesis. If you suppress the ineffective erythropoiesis, there would not be increase in the absorption. There will be less chances of iron toxicity. And generally, in a single transfusion, an attempt is made to raise the hemoglobin by 4 gram per deciliter. Suppose comes with 7 or 8, then we raise by 4. If transfusions are scheduled at 3 to 5 weekly interval, but it should not exceed 12. This has to be taken in kept in mind. Next is a red cell transfusion patient with sickle cell disease. Now there is a difference between thalassemia and the sickle cell disease. In thalassemia, there is a decrease in the hemoglobin chain, but in sickle cell disease, there is a defective chain. So the main aim of transfusion in a patient with sickle cell disease is that proportion of sickled cells should be less than 30 to 35%. You can see in the last line to be sickle cell under 30%. Because if it goes beyond 40-50%, then the patient have those sickle crisis and all the symptoms develop. So PRBC should be transfused. The hemoglobin is more than or less than 1 to 2 gram per deciliter below the baseline, and the patient shows any sign of cardiovascular compromise. Indication remains some acute exacerbation of patient baseline anemia is there, hyperhemolysis is there, hepatic sequestration is there, spleen, aplastic crisis, and all there, which require increased oxygen carrying capacity. In that case, of course, you can give blood transfusion because if a person has a sickle cell population of 40%, if you transfuse 1 unit of blood, then the proportion will decrease to maybe 35% or 34%, that will help in this sickle crisis. During acute life or organ threatening vaso-occlusive episodes and preparation for surgical procedure. Since sickle cells are poorly reformable, simple red cell transfusion that increase the hemoglobin level to more than 10 to 11 gram per deciliter may cause hyperviscosity. So you have to keep the hemoglobin between 10 to 11. So best option is, because very difficult to maintain the hemoglobin, also to see the uh, proportion of the sickle cells which you are giving. So the best option for a patient with sickle cell disease, not transfusion, it's better to do the erythrophoresis or the exchange transfusion. You remove the sickle cells, you transfuse the normal cells. That's the best modality for the sickle cell patients. It's difficult to understand the transfusion therapy in sickle cell because it's multifactorial, multiple factors are involved. Next are the plasma components, which includes your fresh frozen plasma, cryoprecipitates, poor plasma, and 24 hours plasma. I've put the pictures of AB positive plasma just to highlight that this is the universal donor for plasma. This is a neutral plasma. It does not contain any anti-A or anti-B. That's why I put this picture so it remains in the mind. So coming to the indication for fresh frozen plasma. It is a plasma which is prepared within 6 to 8 hours of blood donation. So therapeutic indication when the patient is bleeding, like in massive bleed like trauma or obstetric cases like uh, postpartum hemorrhage, because due to bleeding, lots of coagulation factors are lost. It causes multiple coagulation factor deficiency. Also, when there is a lots of blood loss, there is tissue hypoxia occurs, acidosis occur, hypothermia occur. That again worsens the coagulopathy. So to reverse it, we have to give fresh frozen plasma. Disseminated intravascular coagulation or consumptive coagulopathy with active bleeding. Again, you have to be very careful because it's like say uh, your DIC is there, coagulation is occurring everywhere. If you give more of coagulation factors, it would maybe like putting fuel into the fire. So if patient is actually bleeding, in that case you give FFP. If bleeding is not there, then probably we should avoid giving FFP in such patients. Immediate correction of vitamin K deficiency, 2, 7, 9, and 11 are the coagulation factors, and warfarin reversal. Thrombotic thrombocytopenic purpura. Now, why it is an indication for FFP transfusion? Because it is because of the deficiency of ADAM's 13 enzyme. So, FFP contains that enzyme. So, if you give FFP, then the enzyme is replaced and the patient may improve. In fact, again, the main treatment modality is the plasma exchange, which is done with FFP. You remove the patient plasma and replace it with the normal plasma, the FFP, so that ADAM's 13 enzyme is there in the patient body and the patient may improve. So patient with coagulation factor deficiency like factor 5 deficiency, when there are no other alternative therapies are available for this. Prophylactic indication without bleeding. Nowadays, as they say, FFPs cannot prevent the occurrence of bleeding. When bleeding is there, then they may control it. They may help in controlling the bleeding. So as said, there is no much use of prophylactic transfusion of FFPs, because even if you get the coagulation test, the APDT, PT, INR, they are the poor predictors of bleeding risk. If INR is 2.0 and INR is 3.0, I actually can't say whether the patient is going to bleed during the invasive procedure or not. So they are poor predictors. So with mild to moderate abnormalities, the coagulation test is not associated with bleeding, and prophylactic plasma transfusion in these patients does not affect bleeding outcomes. But the British Council of Hematology, they recommend that coagulation test should be considered in patient undergoing procedure with a moderate or high bleeding risk. Any patient anticoagulant, warfarin patient is taking, or those who have a personal family bleeding history. In those patients, yes, you may give prophylactic FFP just before you stop to take the patient for surgery. Maybe 4 hours, 6 hours prior to surgery, you can give FFP transfer. Patient anticoagulants like warfarin to correct the INR prior to an invasive procedure. And other indications, it's used as a replacement fluid during therapeutic plasma exchange for thrombotic thrombocytopenic purpura and hemolytic uremic syndrome, as I've already explained. In patients with liver disease, abnormal coagulation tests should be interpreted with caution, as some of the patients may have prothrombotic tendency with elevated prothrombin time. So, FFP is recommended only if active bleeding is present or prophylactically for high bleeding risk invasive procedures. Cardiopulmonary bypass surgery, it is used in presence of bleeding only, not prophylactically, or where abnormal coagulation is not due to hepatitis. In neonates, sepsis, because sepsis will cause acidosis and hypothermia in neonates. They're very prone to get the intracerebral bleeds. So in neonates, yes, in sepsis, patient is having hypothermia, you may consider giving them FFP. Again, dosage. FFPs are transfused using weight-based dosing, 10 to 15 ml per kg body weight of recipient weight. 10 to 15 ml per kg of recipient weight. And during massive transfusion, I'll discuss this, that because during massive transfusion, if only red cells are given, it can cause acidosis and other dilutional coagulopathy. So in general, they say after giving 4 PRBC, for every 3 PR, after first we give 4 PRBC, no FFP may be required. Then in the next 3 PRBC, we have to give 2 FFPs. But nowadays, they say because the concept of coagulation studies has changed. Initially, we used to have the extrinsic and intrinsic pathways. Now we have the cell-based model. So with that, they say that if you start FFP along with the PRBC transfusion, then the outcome in a massively bleeding patient is good. So nowadays we are using PRBC and FFP in the ratio of 1:1. We start with PRB. In fact, they say you can start FFP even before starting the packed red cell transfusions. Now, there has to be a rational use of FFP because FFP has so many side effects, so many adverse effects. So, I think there's some confusion here. This is a wrong slide. First is that it should not be used for treating the hypoproteinemias. Right? Sometimes what happens is to treat hyperproteinemia, if the patient cannot afford albumin, then FFPs are given. That should not be done. And second is prophylactic FFP transfusion for patient with for invasive procedure with normally or mildly deranged coagulation test. Normal INR is 1.0, around 1.0. So if it is less than 1.5, FFP is not going to help because the INR of FFP is 1.5 to 1.6. If a patient has an INR of 1.3 and FFP has an INR of 1.6, then transfusion FFP is not going to help the patient. And FFP transfusion will deal with normal coagulation. This is again controversial whether we are in this particular case we are giving FFP not for the coagulation test. We are giving FFP to maintain to decrease the chances of because bleed is there, dilution coagulopathy may occur. To prevent the coagulopathy, we can give FFP, not because to correct the coagulation test. Next component is the cryoprecipitate transfusion. It is rich in fibrinogen, factor 8, von Willebrand factor, fibronectin, and factor 13. We all know for these all components we have the recombinant products. Fibrinogen concentrates are there in the market. Factor 8, again recombinant is there in the market. Factor 13 is also available. So they're not much used to treat these deficiencies. Volume is very less, 10 to 20 ml, but it provides good amount of fibrinogen. So if patient is going to get TACO circulatory problem, then instead of giving FFP, you can give cryo. Mainly used for acquired hyperfibrinogenic condition like liver transplant and the postpartum hemorrhage or any other massive bleed. Because the normal range of fibrinogen is 200 to 300 milligram per deciliter. And once bleed starts, person loses 20-30% of blood, then the fibrinogen level goes down to 100 milligram per deciliter, which becomes an indication for fibrinogen transfusion. So it has been found that if cryos are given in the early stages of massive bleed, then the control of bleed is good and the patient has a the outcome is good. So threshold for fibrinogen replacement is 150 milligram per deciliter, but in pregnancy, in a patient with PPH, it is 200 milligram per deciliter because pregnancy is hypercoagulable stage with fibrinogen up to 6 gram per deciliter. So if the normal in a normal person, the fibrinogen is 250 milligram, it goes down to 150 milligram. So the fall is only 100 milligram. But in pregnancy, the level of 6 and it goes down to 100, there's a big margin. So the fall is very high. So in that case, that's why we keep a higher threshold for pregnancy. And cardiac surgeries are associated with hemostatic defects with risk of bleeding. So it has been found that prophylactic fibrinogen replacement lowers the risk of bleeding. Cardiac surgery, I mean the bypass surgery which are done. Blood goes out, moves through a circuit and come back. In those cases, the hemostatic defects are there, so we can consider giving them fibrinogen. Dose for cryo is 1 unit per 10 kg of body weight. So if a person is 90 kg weight, then nine cryos has to be given. And in cryoprecipitate, there is no need to do even the blood grouping. They can be given across the blood group barrier. Like a person who is A can be given B cryo, B person can be given A cryo. So just remember, for red cell component, complete cross-match is required. For platelets and plasma, the FFP, you have to do the blood grouping. Blood group specific components are to be issued. But in cryoprecipitates, no need to do the blood grouping also. You can even give out of blood group. Right? So if you give this dose 90 units to a 90 kg person, it is estimated to increase the plasma fibrinogen by 50 milligram per deciliter. So if person is having 100 milligram, so after one dose it will be 150 milligram per deciliter, provided there is no bleeding. If bleeding is there, then you may have to give continuous infusions. Next come the platelet components, indications discussed: thrombocytopenia, platelet function defects, and prevention of bleeding due to thrombocytopenia as in bone marrow failures. So these are various thresholds which are theoretical and you may have to remember if required. In a reversible bone marrow failure where recovery is anticipated, then you keep a threshold of 10,000. Below 10,000, you transfuse. Chronic bone marrow failure where recovery is not anticipated, then no prophylactic platelets are required because the platelet count is going to remain low. So you have to manage the patient according to the sign and symptom. There's a WHO grades of bleeding with platelet deficiency, so that can be followed. So accordingly, you can see. Uh, Patient in ICU with there's no bleeding, then you have to keep a threshold of 10,000. Below that, you transfuse. For venous central lines, again 10,000. For lumbar punctures, insertion of epidural catheters. For major surgeries also, like even for cesarean sections, they say 40,000 platelet count is more than sufficient. For normal vaginal deliveries, 20,000 is sufficient. But for neurosurgery and ophthalmic surgery, it is 1 lakh because even a single or few drops of blood in the eye may cause a lot of damage to the eye. For liver biopsies, 50,000. For renal biopsies, if the patient CKD platelet dysfunction is because of the uremia, then even if you transfuse platelets, they are not going to help. The transfused platelets will also become defective. So it's better to avoid platelet transfusion. In these cases, you may consider giving desmopressin, which causes the increase in the vulnerability factor expression on the endothelial cells and platelet activity increase. For bone marrow aspirates, between biopsy, peripheral catheter insertion, and cataract surgery, no prophylactic platelets are required. So in that case, you don't have to give any platelet because chances of bleeding are very less. Therapeutic platelet, severe bleeding is there, massive transfusion patient undergoing, then 50,000. Multiple trauma, brain injury, because when the brain injury is there, lots of tissue factor is released. Lots of trauma-induced coagulopathy is there. Lots of platelets are being used. So we keep a threshold of 1 lakh. Non-severe bleeding, mild bleeding is there, 30,000. And DIC is there in the presence of bleeding, then 30,000 again the thresholds. Platelets not to be used. First is thrombotic thrombocytopenic purpura. In that case, because thrombosin being formed, if you give more of platelets, it's going to cause more damage to the patient. But if patient is bleeding, then you may consider it. Relative contraindications are idiopathic autoimmune thrombocytopenic purpura (ITP), because platelet destruction is going at a very fast rate. So even if you transfuse, it's going to get destroyed. So no point of giving. If bleeding is there, yes, again you can give. Untreated DIC, thrombocytopenia associated with septicemia, or in case of hypersplenia. This is for adults. For neonates, yes. For septicemia also you can consider giving them platelet, because the chances of intracellular bleed are very high with these patients. Dosage for platelets is 1 unit of platelet concentrate per 10 kg of body weight. Again, same as for the cryoprecipitates. So for average man 60-70 kg, 4 to 6 single donor units containing at least to 14 to 10 to 9 platelets should raise the platelet count by 20 to 40,000. So single dose increases the platelet count by 20 to 40,000. And one apheresis platelet, if you're using, that's a big platelet bag, that also increases the platelet count by 20 to 40,000. Increment is less if there is splenomegaly, DIC is there, platelet consumption is high, some immune phenomena are there, so increment will not be there. That is known as that condition is known as the platelet refractoriness. It is when you do not get the expected increase in the platelet count even after giving the full dosage. That is platelet refractoriness. So you have to find out the reason first, treat that reason, whether it is immune or non-immune. If immune is there, you may have to do the platelet cross-match also. If non-immune are there, like DIC and splenomegaly, in certain cases with steroids, it helps. Next comes the granulocyte transfusion. From the WBCs, the granulocytes are transfused. Nowadays, lymphocytes are being used for the treatment of cancer, but I won't be discussing that component because it's a highly specialized component, CAR T cell therapy and all. Granulocytes mainly for the neutrophils we are taking. It is almost exclusively for oncology patients. It treats severe antibiotic refractory bacterial and fungal infection in patients with absolute neutrophil count less than 500 per microliter. One dose contains 10 to the power 11 granulocytes. It increases neutrophil count by 2000 to 5,000 per microliter. It has a role in prevention of fungal infection recurrence in a patient who are immunocompromised, mainly after the hematopoietic stem cell transplants. After preparing the component, should be infused in 24 hours, preferably within 6 to 8 hours. It is stored at room temperature without agitation, like platelets we are doing the agitation. With a normal BT set, do not use the liquid reduction filters, because if you use those filters, granulocytes will also get filtered. And gamma irradiation should be done because it contains lymphocytes which can cause graft versus host disease, which probably I'll discuss in the next lecture. Next, coming to important point is transfusion support and hematopoietic stem cell transplantation. These patients are important because nowadays we are doing the transplant across the blood group barrier also. So we have the major incompatibilities transplant, minor incompatibility transplant, or two-way incompatibility, like the bidirectional incompatibility transplant. Like in first case, if you see, recipient is O, donor is O. It's a compatible transplant. Recipient is O, and the donor is A. So you are transplanting A group cells to a recipient who is O. So it is a major incompatibility, because this recipient will have anti-A and anti-B, which can cause reaction with the A cells. O and B, again major incompatibility. My minor would be donor is O and the recipient is A. So that is a minor incompatibility. Why this? I have taken this separately because when we do the transplant, you can see these lines. Here we have the HPC infusion, stem cell infusion. Before that, in the patient, we have the red cells and the antibodies of the patient origin. If the patient is group group A, then the antigen would be A and antibody would be anti-B. After the HPC transfusion, after a few days, there will be a mixed population of cells. And antibody would also be mixed. So there would be ABO discrepancy. Forward, when we do the blood grouping, we do two types of blood grouping, forward grouping and the reverse grouping. In the forward grouping, we look for the antigen. In the reverse grouping, we look for the for antibodies like anti-A and anti-B. But during this phase, it would be all a mix. Forward, maybe the forward would be the uh, like in this. If I give an example, the recipient is A and the donor is O. After transplantation, in this phase, the forward grouping may become O, but reverse grouping is still A. So there's a ABO discrepancy. So it becomes difficult for the blood bank people also to decide which blood group to give. So for transplant patient, we have to perform the blood grouping before the transplant of the donor and recipient. We have to keep the records. So whenever this kind of confusion comes, we can decide which to give. After the engraftment, when the ANC is more than 500 or engraftment has occurred, then both the forward and reverse grouping is of the donor origin. The recipient becomes O positive. In this phase, the recipient was A positive. In this phase, the recipient will become O positive. But the main problem is the this phase between infusion and engraftment, where there can be any group. So this is a chart with which you can decide which component you can transfuse during that phase between the infusion and the engraftment. I will not explain this in detail. Like in ABO incompatibility, if it is recipient is O, donor is O, it's compatible, so there is no problem. Anything you can give. In major incompatibility, like uh, our recipient is O and the donor is A, so the RBC we give should be compatible with both. So we give O, and the plasma or platelet will be either A or AB. Why A? Because it will contain anti-B only. That is not going to harm either the donor cells nor the recipient cells. And but acute hemolysis can be there. Delayed engraftment can be there in these cases. Why? Because recipient is O, has anti-A and anti-B. You are transplanting A positive cells. So anti-A will attack the A positive cells. So hemolysis may occur. There may be delayed engraftment. Pure red cell aplasia may be there in the acute phase. So you can do the red cell depletion. Minor ABO incompatibility looks very simple, but sometimes become more complicated than the major ABO incompatibility. In this case, like example I gave you, recipient is A and the donor is O. A red cell you give O and the platelet would be A or AB. That's fine. That's easy to understand. But here we again have the acute hemolysis. Why? This recipient has only anti-B and this transplanted cells are O. So anti-B is not going to attack the O cells. Then why the acute hemolysis is there? It is because of the passenger lymphocyte syndrome. In one line, if I explain you, when you are doing the transplant, some other cell lineage are also transplanted. Lymphocytes are also transplanted. So when the lymphocytes from the donor, they proliferate, the donor is O. So the donor will prepare anti-A and anti-B both. So this anti-A will attack the recipient cells, will cause the passenger lymphocyte syndrome. So we'll have the hemolysis in this. In that case, you can do the plasma reduction or steroids or IVIG help in this condition. Bidirectional matlab means we are transplanting A to B. Then the preferred RBCs are O and the plasma is AB, because O is the universal donor for red cells and AB is the universal donor for plasma. This is only during the phase between the infusion of stem cells and the engraftment. Before that, you can transfuse the recipient group, and after that, you can transfuse the donor group, which has now become the group of the recipient also. Now coming to the second last topic, I will not take much time on this. Is the massive blood loss. How do we transfuse in a patient who is massively bleeding? So what is the massive blood loss? Loss of one blood volume within 24 hours and 50% blood volume loss within 3 hours, or rate of loss of 150 ml per minute. If these conditions are met, it's a massive blood loss. Or in practice, patient is bleeding like anything, so you label it as massive blood loss. In the massive blood loss, here it's written severe trauma. It's not only trauma, due to any reason, some other hemorrhage, some vascular injuries there, some other reason, bleeding occurs. When bleeding is there, the blood loss is there, then tissue hypoxia occurs. This tissue hypoxia leads to acidosis because tissues are not getting enough oxygen, because there is a vasoconstriction also. Because when there is a blood loss, to maintain the blood pressure and other things, vasoconstriction occurs. So the blood is not reaching the end organs, so it causes hypoxia. And when bleeding is there, sometimes we transfuse colloid and crystalloid. There used to be a practice to give more of crystalloid. If you give more of crystalloid, the dilution effect is there, and the pressure may increase, which may dislodge the clots, which will further uh, exaggerate the condition of hypoxia. Massive RBC transfusion, again, dilution of coagulation factors and platelets are there. Hypothermia, it causes, and this acidosis will causes coagulopathy. When the pH falls from 7.4 to 7.2, there's 50% loss in the activity of coagulation factors. And for every 1 degree fall in the temperature, 10% of coagulation factor activity is lost, because enzymes, they stop working. The coagulation cascade enzyme, they stop to work. So hypothermia and acidosis, they both contribute towards coagulopathy. Further, it leads to bleeding. So it becomes a vicious circle. Bleeding occurs, hypoxia occurs, acidosis, hypothermia occurs, coagulopathy occurs. Further, due to coagulopathy, bleed occurs. So this is known as the lethal triad of massive bleed: coagulopathy, acidosis, and if hypothermia is there. At this stage, instead of the new concept after cell-based model has come, because in cell-based model it says that it's not only the coagulation factor, fibrinogen, and the platelet surface. It has a very important role in formation the hemostatic plugs, both primary and both the primary and secondary hemostatic plugs. They have a role. So if you, when the bleeding starts in the early phase, instead of giving this colloids, if you give FFPs, which have the tendency to increase the vascular volume, then the perfusion toward the tissue will improve. And if you give red cells also, which are warm, then again the oxygen carrying capacity will increase. Two things are happening if you are giving FFP and PRBC. FFP will increase the delivery of oxygen, or the blood become less viscous also. It can reach the end organs. And then red cell transfusion is being given early, then the oxygen carrying capacity improves. So this acidosis and hypothermia will not develop in this case. On this basis, the current transfusion management therapy has changed. This is again the same thing: trauma leads to death, coagulopathy, and hypothermia, acidosis. We have to treat these things before they occur. It's not that now the main aim is not to treat the coagulopathy. The main aim here is to prevent the coagulopathy. I hope you understand the difference. So the key step to minimize the blood transfusion in trauma patient is minimize the blood loss. This is known as a damage control resuscitation also. Damage control surgeries are there. Some vascular surgeries, vascular injuries there, and some multi-trauma are there. You do not take the patient OT for a complete surgery. You first control the bleeding. You only ligate the blood vessels. The repair surgeries can be done later. Monitor coagulation from early on. Use a viscoelastic matrix that I will discuss. Identify the patient who require massive transfusion. Inform the blood bank immediately. There should be activation of massive transfusion protocol. In the West, whenever massive bleeding patient comes, the physician, they just give a call to the blood bank and they say activate MTP. massive transfusion protocol, and the things get activated, the blood is released immediately. The hematology lab, they start doing the test, the hemoglobin test. These things are done on priority. So that's how we can manage. Immediately the patient should be managed. Administer uh, tranexamic acid, which are the antifibrinolytic agent, as early as possible. Within 3 hours, they say it is good if you give within 3 hours. Ensure optimal coagulation parameters. That can be done by maintaining the temperature, because I told you that temperature causes coagulopathy. pH, you have to prevent acidosis, and calcium level, because calcium is required for the conversion of your prothrombin to thrombin. If calcium is not there, because you are giving so much of FFP also, that can also cause hypocalcemia. And hypocalcemia is a feature of trauma-induced coagulopathy. Consider using smaller tubes to reduce phlebotomy loss. These all things are other, but the main important are fifth point: ensure optimal coagulation parameters, try to reduce hypothermia, maintain the pH and the calcium levels. Limit crystalloids. Initially, we used to give lots of crystalloids, but they say after 10 to 50% of blood loss has occurred, do not give crystalloids, start giving the fresh frozen plasma. Even in the West, now there's a concept that when the patient is being airlifted to the hospital, during that phase only they start giving the fresh frozen plasma. So, origin of I've already explained that we have to give PRBCs and FFPs also, and they say if PCs are also given, then the outcome improves. So we give in the ratio of 1:1:1. One PRBC, one PC, and one FFP. Have written the order as FFP, PC, and PRBC, because now they have identified that role of FFP and PC is more important than PRBC in massively bleeding patients. First give FFP, PC, and then you can give PRBC. Uh, During the Iran wars, due to non-availability, whole blood was transfused. It had better outcome. So concept was that whole blood has a better outcome. If you combine all the blood components, it will have a good outcome. And they found yes, it has a good outcome. I'm reading the last line. As per the modern cell-based theory of plasma coagulation, means that only blood component given in the unit ratio of roughly 1:1:1 RBC to plasma to platelet were likely to be effective in supporting injured patients requiring massive transfusion. Now, what was the concern? They found that increased utilization is there, plasma exposure is more, so lung injury chances are there. It increases the cost, but various case studies were documenting improved survival among patients with life-threatening hemorrhage treated with more equal proportion of blood component and overall decreased blood product utilization. Because if you start the uh, transfusion therapy with 1:1:1 and the bleeding stops after half an hour, then further blood components would not be required. So actually, we are decreasing the blood utilization, not increasing and improving the patient outcomes. So if we put all the components back into it, we combine all the PRBCs and all, we find that the coagulation factors are better in whole blood as compared to the 1:1:1 or 2:1:1. It can be any ratio. We prefer to give 1:1:1. Some centers they give two FFP, one PC, and one PRBC. So ratio is 2:1:1. Like in this example, is 2:1:1. So they found that if whole blood is being given, then the outcome would be good. But I said whole blood should be discouraged. Why? So are we going back to the fresh whole blood? It will contain all the components for coagulation. During the Iran-Afghanistan war, it was found that fresh whole blood is good for resuscitation, and for military purposes, it's well documented. But there's a risk of infection. Within 5 days, you have to give immediately in the military. They take out the blood and transfuse immediately without doing the testing. Sometimes only rapid tests are there, so chances of infection increases. Whole blood transfer up to 8 days has been transferred, but what after that? What to do with that whole blood after 8 days? Even if it is 5 days in US, it may have a role in trauma when blood components are not available. And in our, I mean, in Indian setting, we can use PRBCs, because if we give whole blood, then anti-A, anti-B would be there. And our Indian population, we don't know whether the titers are high or low. So if you give O positive whole blood to a patient who is A positive, then it may cause hemolysis. So they found the next step as low titer O whole blood. That is, check the antibody titers of anti-A or anti-B. If it is low, only then they use as a whole blood. That is known as the low titer O whole blood use. But it again has its limitation. It causes excessive wastage, because finding an O positive bag, then whole blood, then checking the titer, it's a difficult task. Difficult to manage the inventory. If we have 4 units of LTOWB, we call it, and patient requires more than that, then we have to give PRBC, FFP, and PC. So there's no point that if you are going to switch to 1:1:1. So again, this problem. Cost is a problem. Acute staffing shortage and hemolysis. I've already explained, if anti-A, anti-B is there in the plasma of whole blood, it can cause severe hemolysis. Then massive transfusion protocol. It is a profoundly local document. In simple way, I would say we have to maintain a system that whenever patient comes to the emergency, all the services which are involved in the management of this patient, like blood bank, provide the blood component, then the thromboelastography lab should be activated, that they give the results. Then the coagulation tests are required, PT, INR, the hemoglobin values are required. They should get activated. There should be a process flow. So a local document should be there which reflects the patient care needs, available resources, who will interpret the data, and opinion of local individuals, and system that must work together in a stressful emergency. So main components are when and who will initiate MTP, notification of transfusion services and laboratories, laboratory testing algorithm, how they will test, which test they will do first, blood product delivery and preparation, other patient care needs like blood warmer, nursing care, and mechanism for monitoring of outcomes of MTP. Protocol for emergency issue of blood is, if patient is massively bleeding, you don't have time to do the blood grouping, then you can straight away give O positive or O negative red cell, because here the primary our primary aim is to save the patient. So the in emergency issue, O positive or O negative red cells are issued, and plasma is AB positive plasma is issued, right? So we must maintain a good inventory of ORBCs and AB plasma. And the British protocol, which is there for the treatment of MTPs, you first recognize the blood loss and trigger major blood loss protocol, which is a massive transfusion protocol. Baseline samples should be taken, full blood count, group and save, clotting screen, fibrinogen, other hemostatic testing if available, and start the FFP and RBC in a prefixed ratio. Britishers, they give 1:2, some centers give 1:1 as well. If trauma is less than 3 hours, then you give Trenexa, and you can start giving over 1:1 ratio of blood. And then if coordination with the blood bank should be there, that the blood component should be issued. If no time for cross-match, if the patient is very sick, then issue O negative PRBC and AB positive plasma can be issued. And last line, if you see, consider blood warmers, because patient can develop hypothermia, which can further worsen the coagulation. If bleeding continues, then you may continue giving 1:1. Bleeding has stopped, then you can see the hemoglobin values, APDT, fibrinogen values, platelet. Depending on these counts, you can give the blood component. So you continue the cycle of monitoring and giving appropriate blood component until bleeding stops. So one thing has a major role in the point of care testing are the thromboelastography. You have 5-6 slides here, but I will discuss very briefly here. 2 types of viscoelastic assay are there: thromboelastography and rotom. Third is sonoclot, which is a very old method, but still I consider that it's better than even thromboelastography and rotom, though it is not extensively used. So it is based on the viscoelastic property of the clotting blood. In a cuvette, blood is taken, there is a needle, torsion wire is there, which goes into the blood and it moves. Then when it moves, the blood starts to clot. As the blood clots, there is an increase in the resistance to the movement of the needle, and that's a graph is formed. And graph is studied, like you can say, the difference between rotom and thromboelastography is that in thromboelastography, the cup containing test sample rotates. In rotom, the cuvette is stationary, the needle that moves. But the friction between the two leads to the formation of the graph. So we have the R value. It is when there is no resistance, the clotting has not started. And starting from here to 2 millimeter, it is the R time. It is when clotting starts to some amount of clot is there. If R time is increased, that means there is a deficiency of coagulation factors. Then you can see this K time or the alpha angle. K time is when it goes from 2 millimeter to 20 millimeter. It is a time taken, so it's a rate. If the rate clot formation rate is high, that means good amount of fibrinogen is there. If it is less, that means patient is deficient in fibrinogen. Cryos are required. Same is for the alpha angle. Then it comes the maximum amplitude. It is because of the platelets and fibrinogen. Because we know that the firm clot is formed because of fibrinogen and platelets both, as per the new cell-based model. So if R time is increased, so coagulation factors are deficient. So patient require coagulation factors, so fresh frozen plasma is required. If K time is decreased or alpha angle is decreased because their rate of clot formation, so in that case, fibrinogen is less. So patient require cryoprecipitate. If the maximum amplitude is less, that means platelets and fibrinogen both. They both are required. So that's how we can decide which components required for this patient. So the tech variable R time I have explained is a clotting time, initiation of clot. So FFPs are required. If K time is decreased, then FFP and fibrinogen both are required. This should be fibrinogen also. Alpha angle, fibrinogen is required. And if maximum amplitude, which is the maximum clot firmness, then the platelets are required. That's how you can decide. So just for the interpretation, if the cause is surgical hemostasis, patient after the surgery is over, patient is having blood in the drain, and you do the thromboelastography. All this value come normal. That means there is no problem with the coagulation. You don't have to transfuse any component. The physician or surgeon had to re-explore the patient to find the cause of bleeding. If hemodilution is there, so all the factors, the coagulation factors will go down. So your R value will increase. If hemodilution further goes, then even your K value may go down. In factor deficiency, this R value would be high. If this become high, this because it's a stepwise process. First coagulation factors are required, then fibrinogen, then platelet. If coagulation factors are less, then of course the K value will also become either low or not. Fibrinogen deficiency, your R value will remain normal here. So you don't have to, if R value is normal, do not transfuse FFP. Transfuse only fibrinogen, that is cryoprecipitate, or the platelets. Platelet low or dysfunctional, K value may be normal, R value would be normal, but maximum amplitude is less. So in that case, platelets transfusion is required. So advantages of this key, it's a point of care test. Within 5 to 10 minutes, you get the results, and it takes into account the coagulation occurs in the whole blood. It takes into account the role of coagulation factors, fibrinogen, and platelets also. But in the conventional coagulation test, if we are using platelet poor plasma, so role of platelets is not studied in those tests. So drawbacks are that routine plasma tests are 3% less than 10% overall clot strength is represented by PT because they study only the endpoints, the generation of thrombin. So that's why they are not a good test for monitoring the massive leaks. And plasma and role of platelet to clot strength is not assessed. Whole blood is not analyzed. And analysis stops as the fibrinogen is changed to fibrin by thrombin. But after that, the fibrinolysis occurs. Thromboelastography, you can study the fibrinolysis also. Just a few lines about patient blood management. Patient blood management, if I explain you, nowadays the focus is on the patient outcome, not giving more of blood. uh, Initially the concept was like we used to be happy when we manage the massive transfusion, but now they say if you can prevent the massive transfusion, that's the main goal. That is patient blood management. So it is a patient focused, multidisciplinary, evidence based and systematic approach to optimize the management of patient and transfusion of blood products for quality and effective patient care. So patient focus, we have to see the patient, the outcome should improve. You may have to give more blood or less blood, but it's multidisciplinary. You have to take the help of all the disciplines. Evidence has to be there and just be systematic approach. I'll explain this. Scope is to improve the patient safety and outcome by appropriately managing the patient's own blood. If the patient can be managed with his own blood, then you need not to give the allogenic blood product of some other so PBM in medical settings, like for small blood loss and other things, if replacement fluids can work, then you give crystalloids or colloids. Limit the iatrogenic loss. They have found that repeated phlebotomy can cause anemia. Then you have to check the how much the patient can tolerate a low hemoglobin. Like I gave an example of patient with osteoarthritis who is lying on bed. For that, the hemoglobin of 6 is also fine. The patient is non-ambulatory. So you have to see whether patient can tolerate a low hemoglobin or how you can maximize oxygen delivery. You can even give oxygen to maintain the treat tissue hypoxia rather than giving red cell. Monitor the bleeding. Treatment and prevention of anemia. Do not give red cells for an anemia, which can be treated with iron or B12 or other kind of things. PBM in medical settings, there are various studies like prophylactic FFP transient liver disorder has been questioned by a large meta-analysis. They say it doesn't help much. So the studies are now uh, the studies which are going on, they are like to see whether FFP transfusion or blood component transfusion is useful. Is it improving the mortality? So these things are there, and you can use viscoelastic assay to guide the blood component therapy. Like if, as we saw, if the thromboelastic assay is normal, so no blood components are required. Patient may be bleeding after surgery, that may be due to some other reason. You can increase the tolerance of anemia, increase oxygen delivery. You can patient is on ventilator, you can increase the delivery of oxygen. Optimizing hemodynamic status in normal volemia using vasopressors and other adequate pain control and maintaining normothermia and promptly treating infection. In surgical settings, it is divided in three parts: preoperative, intraoperative, and postoperative. In the preoperative phase, if there is any reason for anemia, you treat first that. Then you take the patient for surgery. Not like the patient, if I said the threshold for HB is 9 for a surgical oncology patient. If patient can wait for 2 months, you start the patient on iron, let the hemoglobin increase to 9. Then take the patient for surgery and you minimize the blood loss. Identify the managed blood risk, stop aspirins, stop other drugs which can cause blood loss, and compare the estimated blood loss with patient-specific tolerable blood loss. A patient who has a 7 liters of blood volume, 700 ml will not cause any change. So you have to harness and optimize the physiological reserve of anemia. In the intraoperative phase, you can use new techniques which can minimize the blood loss, time surgeries and all. Meticulous hemostatic and surgical techniques, blood sparing surgical devices are there, anesthetic blood conserving strategies. Like nowadays, they decrease the blood pressure during the intraoperative phase. When blood pressure is low, bleeding would be less. Autologous blood options are there. Before the surgery, you can take out the blood and use it. Harness, optimize the cardiac output and optimize ventilation, oxygenation. In the post-operative phase, you can optimize the erythropoiesis. Because if you give blood transfusion, erythropoiesis gets suppressed. So if you can stimulate the erythropoiesis by giving iron, folic acid, B12, do that rather than giving blood transfusion. We have to be vigilant and management of post-op bleeding and again maximum oxygen. Thank you. I think this covered most of the points which are required to know, we need to know before starting a blood transfusion.
Absolutely right. Everything has been covered. Very extensive. Excellently done. Please stop presenting so that we can see you. Yeah, great. Very extensive. You can put your video on, Dr. Lakhvinder. Yeah. I bet you must be really tired.
Yeah, I need a glass of water, I
Yeah,
guess.
yeah. Please drink a glass of water. Please, please. A tumbleful, please. Wonderfully compiled, very extensive, extremely brilliantly presented. Very nice. Excellent. And the TG is so important. My God. Nowadays. Yes. To identify. Wonderfully done. There is only one question. It actually is not the question related to your topic. One doctor wanted to know where to do MD transfusion medicine. Hello, can you hear me, doctor?
Yes, sir. Can you repeat the question, please?
No, it was not a question. It was a query which a doctor wanted to know on YouTube where to do MD transfusion medicine from.
Where to do? You can do it. There are so many centers. PGI. I mean, it was started in SGPGI, Lucknow. Now PGI is having the MD transfer program for last 15 years, I guess. So there are so many centers now. Even in a new NMC rule, they say that for a recognition of a medical college, Department of Transfusion Medicine has to be there. Probably in
Right.
coming time, we'll have more number of seats for transfusion medicine.
Right.
And you are most welcome to come to PGI and do transfusion medicine.
Yes, absolutely. Yes. So wonderful presentation, Dr. Lakhvinder. We will love to see you for the second session.
Sure, sir.
And I
Thank you
can
so
see
much,
that
sir.
there are no questions on the YouTube. So just your final comments before I close.
So, in the final comments, like don't consider blood transfusion as simple as normal saline transfusion. It's a biological fluid. So you must plan what you want to transfuse and how are you going to transfuse, how much you want to transfuse, and you must keep in account the patient care as well, because it doesn't mean that if you transfuse more of red cell, the patient condition will improve. So you keep in mind all the parameters, the patient comorbidity, and the adverse effect the patient may have after blood transfusion. So you make a decision that whether it is required or not. If required, then how much it is required. Do not give more than what is required. So that will, I think, will help save you many lives.
Right. Thank you so much. Fine. We will close here and we will be, eagerly waiting for the second session. We'll coordinate with you regarding the date and the time. Till
Sure, sir.
then, stay blessed. God bless you. Good night. Take care. Bye.
Thank you so much, sir. Good night.
Please share the PDF of this presentation so that we can update into the Google Drive.
Yes, sir. I'll do that.
Right. Thank you so much.
Thank
Bye.
you. Thank you.
Bye.
Fatima.